So my name is Justin Machia, and I'm from Woodcliff Lake, New Jersey originally. I currently live in Nyack, New York, near the Tappan Zee Bridge. Um, I graduated in 2011, and I chose URI because the intimate feel of the school, the small class size. Um, when I visited the campus, I really enjoyed the beautiful campus and also beautiful Rhode Island. It was my first time going to Rhode Island, and I was with my mom, and we had a really great time on campus and seeing the school. It was the old Fogarty building. And then after that was all done, we went to Narragansett and took a drive down Route 1, and it was just really beautiful and nice. And I thought, man, I can definitely live here, and the proximity to the ocean. So all those things combined.
Oh yeah, definitely. I'm from Narragansett originally, so I
Nice.
I was like, I have to go to URI. It's it's a
Yeah,
no-brainer.
definitely.
All right. So then um now you can just talk about like where you work and what a typical day at work looks like for you.
I'm a consultant pharmacist with Omnicare. I've had a lot of different roles at Omnicare. I've been doing this I've been doing chart reviews as a consultant pharmacist for over a year. I guess the typical day is different if you look at pre-pandemic to current pandemic. Right now, I mostly work at home remotely, although some facilities do request that I come in. And for those facilities, I just have to schedule appropriate COVID testing so the results come back in time so that I can go on site. Also during the pandemic, we are helping to schedule and organize COVID vaccine clinics across the country that CVS is involved with. CVS had purchased Omnicare back in, I think it was 2015. So we're a part of CVS now. So we're helping to get CVS to schedule these vaccine clinics across the country, which is a huge endeavor. And then on top of that, I've also been working kind of like as overtime to help out at vaccine clinics and administer vaccines. So that's actually going to the floors and administering the vaccines to the patients in nursing homes, whether it's in their rooms or they're out in the hallway, and then vaccinating the staff. And just to get more into specifically what my main function as a pharmacist is, as a consultant, is the chart reviews. So every day, just about, I am logging in to typically an EMR, looking at patients' drug profiles, looking at nurse progress notes, looking at prescriber and medical staff's progress notes, whether it's dietary or rehab, a PA, an NP, an MD, seeing how the patient's status may have changed since I last reviewed them a month ago, and then making recommendations. So we write recommendations to the nursing staff or the prescribers, and there is a CMS regulatory requirement that a pharmacist review a patient's chart every month. And there's also the accompanying requirement that if we write a recommendation, that the physician or the nurse respond. And they can decline or accept the recommendation. If they decline, they have to include a rationale. So it's also going back and collecting paperwork from last month and sort of straightening out all your recommendation responses, making sure if they did accept your recommendation that it was implemented, and then sort of tracking that through time, because you're going to be most likely reviewing that patient the next month and seeing how they're doing. So there's a few components to the job. There's the clinical aspect, which is, I would say this is the most clinical role I've had in my profession, in my career, because you have influence over prescribing trends and you have direct impact on patient care. The second piece would be sort of a regulatory aspect. So the CMS regulations are longer and more wordy than the nuclear regulations in this country. So it is quite an intense body of regulation that the nursing homes need to comply with. And much of that regulation is focused on pharmacotherapy, medication regimens, and how the patient's being handled and how things are documented. So oftentimes we're looking at psych note documentation and making sure that documentation meets the CMS regulatory components. We help the facility with regulatory compliance. And a part of that is med staff meetings. So I typically meet quarterly with the medical director, director of nursing, administrator, and usually some of the other prescribers. And we discuss the quarterly trends, how they're doing, their antipsychotic utilization, opioid utilization, antidepressants, anxiolytics, PRN meds, how it compares to sort of the countrywide, how they've been doing since the past year, since a month ago. So we're always looking at those types of trends. At those meetings, I'll present that data, and I will often participate in antibiotic stewardship as well. So we help develop QAPI, which is quality performance improvement measures for the facility. So for example, one QAPI project might be ensuring that if a patient's suspected a UTI, for example, and they start on an empiric antibiotic, one QAPI project might be to track how well the facility is doing at getting the culture and sensitivity report and then switching it to a more specific and targeted antibiotic. So oftentimes, as a part of the antibiotic stewardship committee, that's something that becomes a QAPI target. So we look at the McGreer criteria, the Loeb criteria. We help the facility to maintain compliance with that. And yeah, so quite a bit goes into it. There's also a technology aspect to the job. So clinical, regulatory, and technology. Those are really the three main pillars. The technology aspect is basically keeping up to date, especially a few years ago when all the facilities were going from paper to electronic, that they were, that it was going smoothly, that it interfaced with pharmacy software appropriately, and that oftentimes there were mandates to go electronic for e-prescribing, and if that was or was not going to include controls in narcotics. So helping the facility to navigate sort of the technology trends and changes, and making sure that they would still get their meds and everything would still work smoothly through that transition.
Awesome. Thank you for all of that. That was a good explanation of all the things that you do.
No problem. Happy to help. So that's just the consulting piece. There's also, you could work the bench at Omnicare. You could be an account manager. You can work in administration, corporate. There's a lot.
I actually did my IPI at Omnicare in Coventry, so I got to see a little bit of that, which was cool for my institutional, because it's it's unique. It's not what most people get to do. So I was excited to be able to see that.
Oh, so you've been in-house at Omnicare?
Yeah.
The one in Rhode Island. That's great. I know some people that work there. That's fantastic. Yeah. So working in-house is interesting. I worked in-house on the bench for 6 months at a New York Omnicare, and that was really the first time I started compounding IVs on a regular basis and doing a lot of bulk compounding, because we have pediatric nursing homes that had really niche requirements and wanted specific types of compounds. So definitely a good experience on the bench too.
Yeah, definitely. So do you currently have overnight on-call shifts, or was that more when you're working in-house?
Currently I don't. If DON calls me kind of after hours, I know something's up, and I take the call. But when I worked in-house, this is going back 5-6 years ago. There were times when we'd close on a holiday, but people would be on call, and then sometimes you get a call and you have to run into the pharmacy, unlock everything, make sure you turn all the alarms off. It was a big building so Omnicare pharmacies, they'll employ 100, 150 people. It's a big place. There's a front end. There's a back end that's more like a warehouse. There's an IV hood. So I've been called in to get a morphine drip compounded and shipped out. And it's really because at that time, it's so rare that you have to sort of open the pharmacy and kind of set everything up on your own. and then organize the driver and make sure the stat goes out on time, that it was more just making sure that you're checking off the list and then closing the pharmacy down. So I do have some experience in that. Definitely, because it's not something that you would do often, it was always kind of dreaded by the pharmacist. But I mean, it's necessary, right? Because these patients are, in subacute settings, or in some of these nursing homes are like an acute care setting, and when things go wrong, they need a stat med, and it's Christmas, Thanksgiving, got to go in and get it ready to ship it out. But I've also worked overnight in retail as a floater pharmacist. So it's just, getting like blackout shades and making sure that you can sleep during the day, different strategies.
So you've done it all. You've worked in like all different kinds of settings.
Yeah, so my wife and I, we moved out to Hawaii, and then I worked retail out there for some time. And then I was a floater. I was working like 30 hours a week. I kept my schedule light so we could just kind of enjoy the island for a little bit. But at that time, my supervisor was kind of picking my brain about how things went in New York and kind of liked my ideas. So he started bringing me along to Board of Pharmacy meetings in Hawaii. So that was really interesting. I was seeing how their processes, they were developing different processes to get their records of their pharmacist immunization records, I guess. So it was just like they were going through their process of how to compile data. So it was interesting to go to Board of Pharmacy meetings out there. And I also worked for specialty pharmacy out in Hawaii, which was rare diseases and oncology.
Wow, that's such a cool story. I'm sure, prospective students would love to hear that. So did you have to go through any special training before you entered your career? Did you do a residency or anything like that?
I didn't do a residency. I did go out to, I did apply for a fellowship, and I'm not sure how it is now, but 10 years ago, most of them were through Rutgers fellowship program, and there was a company called ASI who was trying to get into the Rutgers program for the first time, and it was an extensive interview process. They selected me as the final candidate, but then at the last minute, Rutgers didn't want them to join their program that year, so they canceled the program. So that would have been sort of like an industry training that fell through. So after that fell through, I just fell back on retail and started paying off my student debt. So as I was kind of getting out of school and happy to kind of be chipping away at debt and earning income, substantial income, really for the first time in my life, I just kind of wanted to take a break from the books for a little while, and read things that I enjoyed, like literature and things that I just really couldn't find too much time for in the professional years of pharmacy school, because the workload's pretty heavy. And then as time went on, I decided that I always wanted to get into geriatric pharmacy, so I always had it on my radar to become a board certified geriatric practitioner. And then as I worked in specialty, I realized that you can also become certified as a specialty pharmacist. So I thought, when we moved back from Hawaii, I thought I'll either go the clinical geriatric route or I'll continue in specialty. But either way I go, I'm going to get a certification. So I am now a board certified geriatric practitioner. It wasn't necessary for the job, but it was helpful to study for it, because it brushed things up for me and directly help me sort of tweak my recommendations that I make on a daily basis.
That's awesome. And honestly, that's comforting to hear, because now that I'm, going to graduate soon and I'm looking at jobs and trying to line things up, I feel like I keep telling myself like everything's going to work out. Everything happens for a reason. So that is comforting to hear that, it all worked out.
Everything will work out, and everyone kind of forges their own path and finds their way through the profession. I always say one of the best things about pharmacy is you can work in so many different areas and settings. And there's a vast opportunity, with having as far as direct patient care to having an office job, or actually dispensing medication and administering vaccines, or working for companies that are developing technology in the healthcare field that needs a pharmacist input, or working in industry where you're, again, kind of having an office job and doing medical data analysis, or as a medical science liaison, you're going out and communicating um, clinical data to key opinion leaders and prescribers out in the field. There's so much you can do as a pharmacist. And I really credit that to URI, because the professors that I had while I was there, and there's a handful of them, really spent a lot of their personal time explaining to me what's possible, and spending time with groups of us after class who are interested in picking their brain about what it is they did and what their life was like, either while they're a professor or before they were a professor, and what they did professionally and how they got there. And I really started to open up my eyes and see, it's really so many options. And when I took Dr. Esses's geriatric class, and she got me involved in nursing homes and volunteer work at the Kingston Senior Centers, and helping elderly people enroll in Medicare, and the opt-ins and the enrollment period in the fall. That was really the time where I was thinking, I really like geriatric pharmacy and the practice and how it's set up. And it was really since that moment, when I must have been, I don't know, 20, 21 years old, that set me on this path. And now here I am, a consultant pharmacist in geriatric pharmacy. And I really owe that to Dr. Estes. And the other professors too, like Dr. Kogut, I took his pharmacoeconomics class, and that opened up a whole world to me. And all that information turned out to be very helpful in my professional career, because at Omnicare, before I was a consultant pharmacist, I was an account manager, and most of the meetings I would run were cost-effective and formulary meetings, and helping these facilities sort of choose the most cost-effective medication, but not decrease the care. So all of these things combined, when I look back at it, URI really helped me understand all the opportunities there are. And I started to realize, as I was in my professional practice and taking on interns from other pharmacy schools, that some of the other pharmacy schools that these interns were coming from weren't giving those students the same perspective. So I sort of took it upon myself to also take them outside of the workplace, and maybe go out for a lunch or dinner sometimes, and explain to them, here are your options. You should talk to your professors, try and pick their brains a little more, see what's out there for yourself, because if all you're thinking is retail or hospital, there's so much you can do. And you really should understand those opportunities while you're in school, so you can help forge your path later.
Oh yeah, definitely. I feel like the faculty at URI is just amazing. And I feel like I got a lot closer because I've been on a lot of rotations with faculty members. So I feel like I have gotten to know, the faculty a lot better now, because I was always, as a student, I was kind of shy, and I didn't really like go out of my way to talk to professors after class or anything. But being on rotation with them definitely has, helped me talk to them and make me feel like, they're there to help me, which they are, and they make that very clear. So, all right. So the last question I have is, how do you see the role of long-term care pharmacy evolving in the future?
Yeah, well, the pandemic has wreaked havoc on our patient population, and it's tremendous loss, and it's incredibly sad what's happened and the amount of life that's been lost over the past, 9 months or so. I think that as the pandemic wanes and more people are vaccinated, and the disease rates and death rates and infection rates come down, we'll see more elective surgery start to come back up. We'll see more hips and knees. The overall long-term care, the nursing homes and the rehab centers, much more of that is going to outpatient and keeping the patient at home. And that's really the goal. So I see, I think there's an opportunity for pharmacists to coordinate with primary care providers and surgery discharge centers, or their discharge department at surgery centers, to do consulting for patients at home and to do medical reconciliation. Because, having worked in so many different sectors of pharmacy, I know firsthand that retail pharmacists do not have time to do medical reconciliation. They just don't. It's not feasible. So, someone else hopefully will step into that role, and there will be opportunities for, maybe like a bucket of pharmacists somewhere that discharge centers can reach out to and request work and say, this patient's not going to a nursing home, but they are going back home and they're going to have rehab. Here's the notes. Here's the discharge summary. So do a review. You can send your recommendations to this person, primary care doctor, the surgeon, and any sort of hospital to help bridge that gap. So I think maybe that's an opportunity, as more patients are going home and they're not coming to nursing homes. And then there's the assisted livings and group home centers. I think just generally the trend is keep the patient at home and have them go to outpatient centers. So maybe that's a potential solution.
Perfect. Well, thank you so much for doing this interview with me. It'll definitely be helpful for students that are, deciding whether to come to URI. And you said a lot of stuff that, is very true about URI, and I think that it'll be very helpful. So it was really nice meeting you and chatting with you.
It was my pleasure, Erin. Thanks for making the time today, and happy to help. Reach out anytime.
Okay, thank you so much. Have a good day.
You too. Take care.